Well, thanks, ladies. Nice crowd. You braved the wind. So I'm Niki Milleson, Dr. Milleson. My husband and I moved to Star Valley in 2010, and I worked with Star Valley Health since then. Family physician trained, started out doing all the things family medicine doctors can do, delivering babies, seeing patients in the ER, in the hospital, in the clinic, and then just slowly have decreased the amount that I do over time. I am a DO instead of an MD, and I also did a fellowship in osteopathic manipulation, which is hands-on diagnosis and treatment, kind of like chiropractic, but I think way cooler. And now I'm also board certified by the Menopause Society. So the MSCP is Menopause Society Certified Practitioner. So I actually have 4 board certifications. It just means I have a lot of learning to do every year and a lot of money to spend by supporting these board organizations and letting me say that I'm board certified. So, but you can see I've had a lot of education. We've been here for a while. And we're here to talk about menopause. Specifically, the title of the talk tonight is Silent Symptoms of Menopause. Most people think of menopause being what? What's the most common symptom? Hot flashes. Yeah, hot flashes. So menopause, I hope you get out of tonight that menopause is not just hot flashes. So again, I do work for Star Valley Health. I'm primarily doing consultation work for menopause, perimenopause, postmenopause care, and osteopathic manipulation. And I'm in Thane and Alpine primarily. I also do telehealth. I'm licensed in 4 states. I do telehealth in Idaho, can do telehealth in Wyoming, Utah, and Arizona if you have any friends who need a menopause provider. So. All right, so let's start digging in. So silent symptoms of menopause. So when I think about silent symptoms of menopause, it's basically the health risks that come with the decline in our hormones. So the changes are the natural processes, right, that happen as our ovaries start to piddle out, that happen to our body as our hormones decrease. And those changes can become disease. So it's not that menopause is a disease, it's that our drop in estrogen affects so many different body systems that we can actually develop chronic diseases after the drop in our hormones. So again, the health risks of menopause. So I do like to add a little bit of fun into my presentation. So let me show you our fun video here for the night. So back in 1972, so I love the heading of this. They talked about menopause and HRT in 1972. And so why are we all here still just learning about menopause? So I'll watch this fun little reel and then we'll get into that. Oops.
Seasons, I'm talking about life. Don't you see the forgetfulness, the hot flashes? It's the change of life. Oh. My name? No, I ain't supposed to change yet. Well, it says in the article it can start any time after 40. And when it does, it can turn you into an old woman. Oh, no, that doesn't happen nowadays. It's a natural, beautiful time of life. Beautiful. Well, it don't feel very beautiful. I feel like I'm jumping in and out of a hot bed and somebody's twisting a rubber band around my head. Oh, there's nothing to worry about. Look, it says right here, nowadays with simple hormone treatment, there are no unpleasant manifestations. Well, my Aunt Elizabeth went through this and she didn't get manifestation. She got a mustache.
Thanks for putting up with my humor.
On that show.
Oh man. So All in the Family, right?
Yeah.
Actually before my time, but I had seen reruns. But interesting, right? So 1972, that article was helping her tell her mom that hormones are the way to go and you don't have to go through this horrible thing that's going to happen. This is going to help you. It's a beautiful time of life. We're going to help you go through this. That's not the message out there right now, right? So interesting that was the message on a sitcom in 1972, and we will get to why that changed here in a minute. But first, let's define menopause. Anybody know what menopause is?
Hot flash.
Hot flashes. Perfect. Okay. So the technical definition, it's a horrible definition, but it's 1 year to the day of no natural periods, no cycles. How many women actually have natural cycles? Not all of them, right? So really kind of a bad definition. So that's the technical definition, 1 year without cycle. Every day after that, postmenopausal. So make sure you write down that day and then buy yourself a cake. So every day after that, you were postmenopausal, or another word for it is menopausal. And then the time before that is perimenopausal. And perimenopause can start 5 to 10 years before menopause. And it's something we don't talk about, something we didn't learn. So all the symptoms that happen before the change of that menopause. And a third of women is the number who don't actually have natural periods. That can be because they have a type of birth control that stops how they bleed. They've had a hysterectomy. They've had the lining of their uterus burned. They've had chemotherapy and their ovaries shut down naturally. Those could be other reasons. Come on in. So what really happens is our ovaries just decay is a good way to think of it. We're born with the number of eggs that we're going to have for the rest of our lives. And then our ovaries just slowly decay until they're done. And we'll go over that. But basically, a better definition would be outliving your ovarian hormone production. Or your ovarian journey into retirement. Or a better definition would be the menopause transition. It's not one day that your ovaries decide they're going to just turn off. It does take that perimenopausal time period. It takes 5 to 10 years for our ovaries to decide they're not going to produce enough hormone to allow for reproduction anymore. And so in reality, the average age being 52 for that one day, we live 30 to 40% of our lives after our ovaries decide to shut off. That's a long time. When were our bodies designed? They weren't designed now when we lived to our 80s to 100s, right? They were designed when we actually only lived to probably 40s. We were lucky if we survived an infection, a broken bone, childbirth. We didn't live very long. So we're living a long time compared to when our bodies were designed. So to me, it's a natural process, but maybe we could do a little help with modern medicine. All right. So I like to give an overview of the endocrine system. There are several different organs involved. The organs that we primarily think about would be the hypothalamus in the brain, the pituitary gland, and then the ovaries. But the rest of the organs include the adrenal glands on the back of our kidneys, our pancreas, our thymus gland, which is probably a gland you've never heard of, that's in our chest, and then our thyroid gland. So these are the organs and glands that make up our endocrine system. So this is that demonstration of what happens to our ovaries. So when we're inside mom, we have about 2 million ovaries. By the time we're born, we've already decayed about 1 million ovaries.
Wait, ovaries?
Not ovaries, sorry. Thank you.
Okay.
Perimenopause.
Example. Wow.
Welcome to America. All my peri symptoms tonight. All right. 1 million eggs. By the time we actually get to puberty, somewhere in here, we already dropped our number of eggs. We only have about 200,000 eggs left. In our optimal fertility time period, we continue to drop our number of eggs. And then in our 30s, we start to, our ovaries start to age more. The eggs get a little more stale. And then in our late 30s, we get this large drop off of the number of our eggs. By the time we're in our early 40s, we really only have about 10,000 eggs left. And they're not very efficient eggs. They're kind of stale. They don't function as well as they should. And then this slide says 51, technically 52 is the average age of menopause. But again, that could be a wide cycle. The main hormones we think about, this says estradiol, and I'm going to go into that in a second, but estrogen, progesterone, and testosterone. So these are the main three hormones we think of when we talk about our hormones. But estrogen, we actually have 4 different types of estrogen, and I just wanted to review that for you. So we have E1, which is estrone, and that is a pretty crappy estrogen. It doesn't really support our body systems. And really, it's made by our fat cells after menopause. So that's one of the reasons why we think we get so much adipose tissue around our abdomen, is because our fat cells, our body wants estrogen in any way possible, even if it's this crappy E1. And so that's one of the thoughts of why we start to get that adipose tissue. E2 is our main reproductive estrogen, and this is the main hormone that all the body systems like. You all got this handout tonight. When we talk about what estrogen, what body parts like estrogen, it's mainly estradiol that the body enjoys. Estriol is mainly a hormone of pregnancy. And there's actually E4. It's really only made by the fetus during pregnancy. But we've been able to replicate it. And there are some birth control pills and other hormones that are coming out. And it's actually been a very good hormone to use for birth control. And we're seeing a lot of people feel better using it during the perimenopausal phase, because it's a little bit more bioidentical like the estradiol would be that we use for hormone therapy. So it's a new player out there. It's not a new player. Our body knows that it's been there all along, especially if you've been pregnant, but it is new in the hormone game out there.
Quick question.
Yes, ma'am.
So there's E2 estradiol.
Estradiol.
What is the difference between that and O estradiol that's on the sheet?
Yes. British spelling.
Oh, really?
These are the British resources that I found are way better than any American resource. So yes, good question.
Okay.
British spelling.
Got it. Thank you.
Good question. Okay, so estradiol is what we're going to mainly be talking about tonight when I say estrogen. Okay. So in case you don't remember from biology class, I wanted to go over your normal menstrual cycle. So day 0 or day 1 of your menstrual cycle is the first day of menstruation. So this is a normal during our reproductive years. And you can see, so estrogen, progesterone are the lowest during that time in your cycle. They will be low until you're done bleeding, and then estrogen starts to kick in. Estrogen is actually produced by the ovary. So these are the little eggs. My pointer's not showing, is it? Okay. Laser pointer. How about now? There we go. Okay, so these are the little eggs that get recruited. Several get recruited each month, and one becomes the primary follicle, and it starts to produce estrogen, starts to develop an egg, gets bigger and bigger. Our estrogen levels rise, we get a peak in estrogen, and we get ovulation. So ovulation here is actually a cyst that ruptures into our abdomen. So our ovaries naturally make cysts. I know we think of cysts as abnormal, but that's the natural process that happens in our ovary. And then that leftover cyst, you see it's in this orange demonstration here, is what's left over, starts to make progesterone. So it's called the corpus luteum. So you'll see on the graph here, progesterone starts to rise. Estrogen starts to rise again as well. Everybody wants a pregnancy, goes, oh, no pregnancy. Okay, everybody, bye-bye. We'll see you next month when we get a new egg. Everything drops off and we start over. So that's what should be happening in the normal menstrual cycle. This is a kind of a lifeline of our hormones. So estrogen, progesterone in childhood, puberty, estrogen, oh my God. Monthly reproduction over and over. Everybody's lining up and doing the same thing. And then in perimenopause, oh my God, estrogen. What does that mimic? A little puberty in reverse, ladies?
Yeah.
So hopefully you don't have teenagers in the house when you're going through perimenopause, but if you do, you're doing the same thing. So estrogen all over the place as our remaining stale eggs start to try to still do their thing. You can see progesterone is in this more kind of slow drop. That's the blue. And then after menopause, they don't actually go to zero, but they go to quite low. So that's the overall lifespan and a demonstration of what happens to the estrogen. I had one more slide here. So estrogen, progesterone, testosterone. Testosterone is more of a gentle decline over time. It doesn't drop off the cliff. Progesterone, again, more of a gentle decline. And that's one of the first things we see drop. So when women start to have irregular cycles early in perimenopause, it's mainly because of the drop in progesterone. And then estrogen is, whoa, and then everybody stops. So a little hormone chaos, if you will. So let's go back to our three female hormones. So estradiol, progesterone, testosterone. And I want you to think of these. These are not just reproductive hormones. These are not just running our cycle. They are body hormones. And I gave you these handouts that demonstrate all the different things that estrogen can do in your body. We think of women have estrogen, men have testosterone, but we both have all of the different types of hormones. Men have estrogen and progesterone as well. They just don't have ovaries that produce them. All right. So all these hormones, like I said, they're responsible for actions across the entire body. They're responsible for our cardiovascular health, our bone health, our skin integrity, mood, cognition, libido, energy, immune function. So if you can, you know that the name of the talk tonight was silent symptoms. So this is a hint of what that means. Let's go into estrogen a little bit more. So you have this handout, demonstrates all the different ways that estrogen affects multiple systems. So again, I want you to think of estrogen as a systemic hormone, not just a reproductive hormone. The main actions that we see estrogen do are it's an incredibly protective hormone. When it decreases, we actually lose a lot of anti-inflammatory benefit from this hormone in our body. And this is one of the theories why we start to get chronic systemic inflammation, which can affect all of these systems of the body. So brain, cognition, bone, musculoskeletal health, cardiovascular protection, skin and connective tissue integrity. Next, just progesterone. Again, all different systems. Primarily, we see it works with estradiol, manages the menstrual cycle. It's the main pregnancy hormone. And it also, in our brain, is a calming hormone and can affect our mood and our sleep. Testosterone, again, these are all the different processes. I wanted to make sure you had the ability to take this home and look through that and be impressed with what all these hormones do. Testosterone is also a player in the body. Think of estrogen like the CEO and testosterone's like the chief operating officer. So those are very important hormones that do way more than we know. So libido, muscle mass, bone strength, cognitive function, and then just overall energy levels. So when we think about our symptoms, we think of this. itchy, sweaty, bloaty, sleepy, forgetful, psycho. For this.
Oh my gosh.
If you have not seen this yet, we are going to watch this video. So give me a second to find her. There we go. Okay, so this is not a fake video. Flash, 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 flash. Hot flashes, right? That's all the menopause is.
I consider myself lucky to have that.
All right.
Kind of easy.
So just making sure you're still with me here.
Yeah.
Okay, so the not so silent symptoms of menopause, everything we go to the doctor for, right? Hot flashes, cognitive changes, mood changes, weird things like changes in body odor. We can have irregular heartbeats, palpitations, breast pain, bloating, urinary symptoms, tingling in your extremities, fatigue, anxiety, depression. These are all the symptoms we feel. So now we're going to dig into the silent symptoms, the things we don't feel, the things that are happening in the background that are actually more risky to our health. So even things we can't see or feel do impact our health and longevity. And the transition comes with changes to multiple systems, changes to our brain, our heart, our bones and muscles, our metabolism, and our genitourinary health. So it increases our risk of osteoporosis, coronary artery disease, diabetes, neuroinflammation, gain of fat around our organs, and decreased muscle mass. Hi, our Zoom participant. Thanks for joining. I'm Dr. Milleson. We're heading into the silent symptoms, so it's a perfect time for you to join. All right. So, unfortunately, remember that first video I showed, 1972, normalized hormones at that time on a 1970 sitcom. But where are the hormones now? Anybody know? Where'd they go? Why are we not on hormones today? Okay, so the WHI. So you'll hear me, I'm going to refer to it as the WHI. WHI is the Women's Health Initiative. So there were a lot of studies in the 1980s and 1990s that were what we call observational studies. So there were studies that were looking at different groups. The researchers knew the participants, they knew what the treatments were. And so there's bias in those studies. Those are called observational studies, but those studies suggested that hormones decrease the risk of heart disease. And so we're starting to get in the late 90s, early 2000s, we're starting to get into the time period where we wanted to really prove our science in medicine. So the gold standard study is something called a double-blinded randomized controlled trial. So that means that neither the participant nor the researcher know who's on what. That's the gold standard study that tells you the best information. So the National Institute of Health put billions into this. This is the late 1990s. Billions was a lot of money. They recruited 161,000 women into this study. And the point of the study primarily was actually to look at the prevention of heart disease with hormone therapy, because we had these observational studies and multiple studies showing that we were preventing heart disease. So unfortunately, though, it was halted early because of the C word. There was a media presentation of the data before the study was even written that hormones increase your risk of breast cancer. If you say the C word, everybody stands up and takes notice and says, okay, I'm done. And that's what happened overnight. So just to tell you a little bit about this study, to study this, so there were women who are going to be on hormones and women that are going to be on placebo. What happens to a woman who is really symptomatic with hot flashes and you put them on hormones? What happens?
They feel great.
They feel great. Their hot flashes go away. Guess what? Those women know that they're on the treatment dose, right? They're not on placebo. So they had to recruit women that were not symptomatic. Guess what happened? They did not recruit women who were going through the menopausal transition. They recruited women that were older. The average age was 63. What's the average age of menopause? 51, 52. 10 years after menopause, these women were recruited because they were asymptomatic. Seems like the wrong population, right? Also, a lot were on cholesterol medication already. A lot were on blood pressure medications. Several had heart attacks already. Several already reported chest pain at their initiation of the study. 138 had stroke already. 10% were smokers. 40% were past smokers. 4% had diabetes, and 70% were overweight or obese. So it doesn't necessarily reflect the average woman going through menopause in their early 50s. So that's one of the big takeaways from the study. If you're here late, you're allowed to call me on my Perry moments. All right. So where were you when there was the first moon landing? Was anybody old enough for that?
No.
Okay. Where were you when Jerry Garcia died? Where were you when 9/11 happened? This is what it was for physicians when this study came out. July 2002, overnight, everybody calling their doctor's offices wanted to come off their hormones overnight. It was the Today Show. A doctor went on. Unfortunately, this doctor who did the announcement was really bad at statistics. And it was, to me, it's like the first fake news event that ever happened. And I'm going to go through those details for you. But what they announced was hormone therapy causes breast cancer. Again, the study wasn't even published. The doctors couldn't even read it to tell their patients whether it was something they need to worry about or not worry about. So first fake news event, July 2002. That is the month I went into medical school.
Oh.
So guess what I learned in medical school? Hormones bad. Hormones are bad. Took a long time for me to learn that that was not true. So fear cells, the C word was heard around the world. Okay, so I do want to go through this population with you. So again, remember they were studying hormones versus placebo. So you weren't supposed to know if you were on hormones or not. There were technically four groups. So women with a uterus need to be on progesterone and on estrogen. They use synthetic hormones. So you'll see these CEE and MPA. CEE versus placebo. So CEE is conjugated equine estrogen, which is synthetic hormones. And medroxyprogesterone acetate is a synthetic progesterone. So if you have a uterus, you have to be on both to protect the lining of the uterus. If you're on estrogen alone, it can build up the lining of the uterus, increase your risk of uterine cancer. So there were two pills. The company donated the pills to this, well, didn't donate, but it was thought to be simple because it could be one pill or another pill or a placebo pill or a placebo pill. So this group, placebo or a combo pill, placebo or estrogen only. So those were the four different groups. So what they found is this is the group that stopped the study. So CEE plus MPA. The study stopped because they reported a 25% increased risk of breast cancer. Would you stop your hormones? 25% increased risk? Probably, right? So what they reported was that on the Today Show. So the placebo group, their risk of breast cancer after 5 years of the study, 4 out of 1,000 women were at risk for breast cancer in the placebo. They were not on hormones, so no hormone, sugar pill. The hormone group, 5 out of 1,000.
Oh my gosh.
That in what we call absolute risk is 24% increased risk. Sorry, not absolute risk, relative risk. Relative risk is a combination of the two groups. Absolute risk, the risk to a population. So relative risk, 25%. Absolute risk of getting breast cancer from these two hormones, 0.8%. Not a thing. Not even statistically significant. So fake news event, they reported the wrong statistics. Overnight, the world exploded. This study has been looked at over and over and over and reanalyzed, and several, and what they actually found initially in the estrogen or the CEE alone group, in women who were on the estrogen alone group, after 20 years of following this group, they had a 23% decreased risk of breast cancer. Anybody ever heard that?
No one talked about it.
They also had a 40% decreased risk of dying if they were diagnosed with breast cancer while they were on the hormone. No one's ever heard this, right? But they heard the C word, cancer, stop. So absolute risk is what I'm going to be reporting out when I report any statistics. So not an actual risk of breast cancer. The next slide I'm going to show you actually even teases out more. And I just love this slide. And I know it's a little probably too deep, a little too nerdy, but I love it. So this was that combo group. So the estrogen and progesterone plus placebo. But what they didn't take into consideration, this was not actually a study that was studying hormone therapy. and risk of breast cancer. It was studying risk of cardiovascular disease. So they didn't actually risk stratify these groups appropriately to have the power to test for breast cancer. So what age were the women, the average women in this study? 63. How many people do you think used hormones before they were enrolled in the study?
0
A lot.
Oh,
of the 63-year-olds.
Yep. They went on hormones at their 50s. And they had been on them for a period of time during their transition and were not on the hormones when they entered the study, but had already been exposed to hormones. So when they took those women out, so this is the study with all the women in this group, placebo versus estrogen and progesterone. When they took the women out who had ever been exposed to hormones in their lifetime before entering the study, look at the lines. No difference. No difference in breast cancer risk. The placebo group here had an abnormally decreased risk of breast cancer. When they took out the women who had been on hormones before they entered the study, the placebo group and the hormone group evened out. So again, fake news event. Hormones don't cause breast cancer. Any questions about this? I know this is a really nerdy slide, but I love it. Okay. The other part of this is after the study halted, what do you think we should have seen if hormones cause breast cancer? What should have happened to the incidence of breast cancer after this study was stopped?
increase in breast cancer.
No, after the study was stopped, the whole world stopped their hormones. It should have decreased. Yeah, it didn't.
I don't know the way around too, but it didn't decrease.
2002, the risk of breast cancer increased by 0.5% every year since the WHI was stopped in 2002. It's not hormones that cause our breast cancer. It's other things that cause our breast cancer. So, and guess what age group gets breast cancer? Women in their 60s. And women in their 60s going on hormones? No. So it's not the hormones. One more little slide about risk of breast cancer. So again, the Brits have way better data because they have a smaller population to study. So I did steal their data. I just love this slide better than what I was able to find about the US risk statistics. So just at a baseline, so in the British population, so in the UK, 23% risk or cases of breast cancer per 1,000 over the next 5 years. So there's an additional risk of breast cancer in women. 24 more cases will be diagnosed in women who are overweight or obese. We know that weight issue greatly increases our risk of any cancer, especially breast cancer. Women who drink 2 or more units of alcohol a day, there'll be 5 more cases of breast cancer in those women from baseline.
What does a unit?
So wine, 5 ounces of wine, an ounce of hard liquor, a beer, not a Melbourne beer. So that's a unit of alcohol. So basically 2 or more drinks a night. And then, so this is what the old data, if they keep in so for the 4 more cases of women on combined or HRT, and then 3 more cases of women who are current smokers. But look, if you can get the exercise in that that we recommend from week to week, 2.5 hours of moderate exercise per week, we see 7 less cases of breast cancer in women who get that baseline exercise. And then 4 fewer cases in those women. So this is based off of the Women's Health Initiative, and there was actually a study called the nurses study in the UK that showed similar data. But again, skewed data with those 4 cases. We already saw this no risk of breast cancer when you're exposed to hormones. Okay, so the positives that came out of it. We actually saw that estrogen is primarily what I'm talking about, decreases your risk of colon cancer by 30%, decreases your risk of bone fracture by 50%. The estrogen only arm showed decreased risk of breast cancer by 23%. We went through that. There's a decreased risk of all-cause mortality by 30%. That basically means if you start hormones within 10 years of menopause, you have a 30% less chance of dying. That's what mortality means, less chance of dying. And this is something called the healthy cell hypothesis that came out of this. There were women who were enrolled in their 50s. When they pulled those women out of the Women's Health Initiative, those women had a greater improvement in their health outcomes than women who started hormones 10 to 20 years after menopause. So estrogen is better at preventing rather than treating disease is basically the hypothesis that came out of that. So there is this window of opportunity that we should be really talking to patients about getting on hormones. And then there was actually a decreased risk of heart attack by 40% if women started hormones within 10 years of menopause. And of course, it's the most effective treatment for vasomotor symptoms.
What's the base one?
Hot flash, night sweat. Yep. Anybody read this article? This is really the only article that did announce that women have been misled about the data. So if you're interested, the New York Times did actually do an article, but nobody knows about all the benefits from the Women's Health Initiative. So we talked about the Women's Health Initiative. The hormones that were used during the Women's Health Initiative were the synthetic hormones. Has everybody heard of bioidentical hormones? Okay, so the majority of what we use now are bioidentical hormones. Bioidentical hormones are as what we call body identical, or as close to what our own body makes. So I have never actually prescribed CEE or MPA. It's not in my repertoire because of the Women's Health Initiative primarily, but they're also oral, and there's some risks that come with oral estrogens, primarily a slightly greater increased risk of blood clots, a greater increased risk of decreasing libido. We can see a change in liver function tests, and we see a change in cholesterol levels. And some people get a slight increase or an increase in their blood pressure from oral estrogen. And that's more with CEE. But we now have all of these bioidentical hormones. So what was the main estrogen that we like? E2, estradiol. These are all bioidentical estradiol hormone treatments that we currently use. We have patches, we do have pills, we have a spray, we have a gel pump, we have gel packets, we have a vaginal ring, and then I threw in natural micronized progesterone. This is the body identical progesterone that we use the majority of the time, and testosterone gel. So we use primarily body identical. You do not need to get compounded bioidentical. Compounded bioidentical means you go to a pharmacist who can make recipes of prescriptions and then supposedly make the recipe right for you. I've had a lot of patients use this. I don't prescribe it. It seems to be different every month. I have patients come in and say, my pharmacist really nailed it this month, but last month it was just bad. I had so many hot flashes, but the prescription didn't change. It was supposed to be the same. These are all FDA approved. We know exactly what you're getting. These are all bioidentical versions that you get at your pharmacy that your insurance will cover. So when we're talking about treatments that we use now, this is what we're talking about. We do recommend using mainly a transdermal. The difference being transdermal goes right into the bloodstream, goes right into the bloodstream as estradiol. If you take a pill, it goes into your gut. The liver gets it first. The liver breaks it down into E2 and E1. We don't like E1. We like E2. So we don't get all of the hormone anyway. And then that also increases our risk of clotting factors, raising our blood pressure, lowering our libido, because there's something called sex hormone binding globulin that also gets made by the liver with this process. So we just prefer to use the ones that go right into the bloodstream.
So why would anybody use the oral?
Convenience.
Ask me.
Convenience for some, but it is considered contraindicated in people who have diabetes or high blood pressure or have had any other high risk conditions. majority of women can use transdermal without any complications. So I primarily try to get my patients on transdermal because if they can get used to using transdermal from day one, it's going to be easier. You know, if they do develop a complication later on in life, it's going to be easier to keep them on that transdermal than switching them off of an oral that they've been so used to. Good question. Okay. Okay, so back to the silent symptoms of menopause. What y'all came for? All right. We're going to start at the bottom, the genitourinary system. Okay, if you didn't have good anatomy class, I did not use a front-on view of women's genitalia because we are broadcasting. So, but side view, we have the labia majora, the labia minora, so the hairy part, the non-hairy part. In here is where the vagina and the urethra. So this is the bladder and the P tube called the urethra. You have the uterus, your ovary beside, and then the vagina. So when we talk about genitourinary silent symptoms, we actually are talking about all of this area. A decline in specifically estrogen and testosterone can really affect the health of this area. Specifically, we can see a decrease in the strength of the pelvic muscles. We see the collagen thin, the mucosa, which is the lining like the inside of your cheek, that tissue will thin. The non-hairy area of your vulva can resorb and disappear. That area protects the urethra, which is the opening of the P tube, and that can increase our risk of bladder infection. The changes in estrogen will cause our vaginal pH to rise. During our reproductive years, our vaginal pH is acidic, and it will become basic after menopause. And that changes the protective bacteria that live in our genitourinary area, and that also increases our risk of bladder infection. And then the blood flow can decrease. So bladder infections is one of the main things that can kill us at certain ages, especially in our older years. It's a main reason for admissions to the hospital after a certain age. Not a main reason, but a large reason a lot of times. Oh, grandma had a UTI. She got admitted to the hospital again. She's on antibiotics again. A bladder infection could lead to a blood infection. A blood infection can lead to death. So vaginal estrogen for everybody. So systemic estrogen can help prevent the symptoms that happen in our genitourinary symptoms, but in our genitourinary area, but a lot of times we also have to add a little local estrogen. So I wanted to highlight this. When I say vaginal estrogen for everyone, I really mean it because, again, bladder infection can lead to blood infection can lead to death. If you prevent the decline in the health of our genitourinary tissues with estrogen, you can prevent death. So if you don't learn anything else tonight, vaginal estrogen prevents death. Thanks for staying with me. Okay, so creams, rings, tablets. This is a cool new brand name with these fancy vaginal suppositories. And then there's other treatments. This is called vaginal DHEA, and then this is an over-the-counter vaginal moisturizer.
Are there any side effects
to vaginal estrogen? Not really. Majority of women, I'd say 90% of women, 98% of women. There's a few women with rare genitourinary cancers, specific type of ovarian cancer, who cannot use vaginal estrogen. Some women don't like the formulation of the cream because the components that make up the cream. And so then we just try sometimes either a branded or we try a different generic because the different generics made by different pharmacies. Sometimes we do have to do a compounded or something else, but it's probably the most common side effect, which is very rare, would be local skin irritation. If their skin just doesn't enjoy the components that make up the base of the cream. But the estrogen itself, our tissues are actually craving.
So another question then, because you're obviously liking this, what is the benefit this one versus the topical, the spray?
Yep.
And what would you?
So the hormone levels that we have in our body. So if you remember back to the hormone levels I showed you during the normal menstrual cycle, they range somewhere between usually 50 to 300.
Okay.
So in our lowest, usually around 50. In our reproductive time, we're more in like 300s as we're growing an egg and getting ready for baby. The levels that we get with systemic hormone therapy, so either patch, gel, spray, or pill, don't usually get up to those levels. So we don't get the level of estrogen in our vaginal tissues that we need to support the health of the vaginal tissues. And so that's why sometimes we have to add okay, here's your vaginal estrogen.
You do in addition.
In addition to.
Oh, God.
In addition to, yep. So it's an add-on if your systemic hormones aren't reaching that far. Make sense?
Copy, yep.
Okay.
And one more.
Yes, ma'am.
You said that one of them was like suppository
This
for
one here.
DHEA.
Oh, this one, Intrarosa. Yep.
Yeah, so isn't that the precursor to make
Testosterone.
testosterone? So how does that help with estrogen?
Testosterone, there's a lot of testosterone receptors in our vaginal tissues. We prefer to start with vaginal estrogen. If you're not getting the symptom relief that you need, it's just an extra tool.
Okay,
So that's why it's kind of hidden down here in the corner.
got it.
We don't use that one primarily, and it's branded and it's really expensive, and women don't seem to like it because it can be messy. It's nightly, whereas the vaginal estrogen is usually twice a week.
It's not every day.
Yep. Vaginal estrogen is twice a week. Systemic estrogen is daily.
Twice a week for the rest of your life.
Yes, ma'am. It's like, so when you saw your first wrinkle, did you up your game? Did you up your game on your cream regimen? Did you get a little vitamin C cream, a little tretinoin, a little hyaluronic acid? It's time to up the game on the badge, girls. Okay? Okay. All good questions. I am going to run everybody.
Seriously.
That should be your bumper sticker. Time to up the game on the badge, girls. Okay.
So everything.
Silent symptoms of bones and muscles. So there is, if you want to really geek out on the musculoskeletal system. So Dr. Vonda Wright is an orthopedic surgeon and has done research on the musculoskeletal syndrome of menopause. Musculoskeletal syndrome of menopause happens in about 70% of women. If you look back at your estrogen, estrogen supports the tissues of our musculoskeletal system, not just our bones, but our joints, our ligaments, our tendons, our synovial fluid. And she did the primary research, and she actually tagged the name musculoskeletal syndrome of menopause. But we see in the menopausal transition an increased risk of bone density loss, increased risk of osteoarthritis and musculoskeletal pain, and a loss of lean body mass and mobility. So 1 to 2 years before the last menstrual period, so in perimenopause, we get this rapid loss in our bone density. It's before even our last period. It's during perimenopause. That risk, that fast period of loss happens for about 3 years after our last period. And then we'll start to decline. So over the first 10 years, so the 2 years before our last menstrual period, and then the next 8 years, we will lose on average 10% of our bone density. Not awesome. So fracture is definitely something we want to try to avoid. So this also is accompanied by a loss of bone quality and strength and ability to risk breakage or fracture. So estrogen inhibits the resorption of bone, it supports the building of bone. I've got some pictures to that. It's a 30 to 50%, depending on the study you see, decreased risk. In the US, estradiol is approved to prevent osteoporosis. And in the UK, it is approved to prevent and treat osteoporosis. Estrogen is also anti-inflammatory in joints. If I have someone who has a lot of musculoskeletal pain and I put them on estrogen, they come back in and they go, I can move again. I don't hurt anymore. I've had patients come in at the beginning of menopause and they look like they have rheumatoid arthritis. They have pain everywhere. As a physician, you have to rule out all the bad stuff. So I do all the tests. I rule out the autoimmune rheumatoid situation. And then I go, here's your estrogen. And they come back and they go, thank you. So it's a pretty incredible process that happens in more than just our genitourinary area. 30% decreased risk of knee osteoarthritis with hormone therapy was seen in a 2019 study. And the AAHI, when they actually looked at it, there was a significantly decreased risk of hip and knee replacements with the women who are on hormone therapy. So here's just, I like pictures. So this is what happens on a normal bone. Our bones are constantly breaking down, building up, breaking down, building up. When we have estrogen to support this, this is a pretty equal situation. We build our bone bank by the time we're in our early 30s, and then we have things like a kid, another kid, we might have an illness, things like that, that can lower our bone density if we develop any chronic diseases. But pretty much we get to our maximal bone density in our 30s. This is where estrogen supports our bones. So estrogen helps to prevent the breakdown. So it's a little backwards. There's these little guys called osteoblasts and osteoclasts. Whoever named it backwards. It was probably a man, but thank you. Everybody's still listening. So osteoclasts actually break down bones and osteoblasts build bone. I know there's an explanation, and I learned it somewhere in medical school of why they named that, but it's, again, backwards in my brain. So this is what happens. So during our normal reproductive years, bone resorption equals bone formation. But after menopause, late perimenopause, early menopause, bone resorption starts to outpace bone formation because estrogen supports the bone formation side of things. If you develop osteoporosis, 50% of women with osteoporosis will experience a hip fracture. That's 1 in 2. A third of adults who have a hip fracture, if they're greater than 65 years of age, will die within the next year after their hip fracture. So again, silent symptoms. These are the stuff that we actually really need to know about menopause. It's not the hot flashes. This is the stuff that kills us. So this is the stuff you really need to pay attention to. This is a busy slide, but just a demonstration of estrogen being anti-inflammatory in joints, supporting the health of cartilage, synovial fluid, collagen in our joints, supports the strength of muscles, tendons, ligaments, decreases spinal cord response to pain, and supports nerve health. I'm actually, my pain specialist is actually sending a lot of consults to me now because he's seen the literature and he knows how much hormone therapy can support our musculoskeletal system. And so he's really encouraging a lot of patients to look into this now. Smart guy. All right. Next, metabolic silent symptoms. So metabolic syndrome, you've never heard of this. So diabetes, insulin resistance, high blood pressure, fat accumulation around the organs, which is visceral obesity. We start to see a rise in our LDL, which is our bad cholesterol, a rise in triglycerides, which is another form of bad cholesterol. So we can start to see our blood sugar and insulin rise. We can lose lean body mass. We gain fat around our organs and our liver. A lot of times we don't actually see a change in the scale, but all of a sudden my pants don't fit. I get that little minnow muffin, right? I have sleep disruptions on here because as a not so silent symptom of menopause are sleep disruptions. So poor sleep, it can be kind of like a silent symptom. It increases your appetite, increases your risk of fat storage, makes you more lethargic, less likely to eat or move like you should, can decrease your metabolism. I put mood changes on here because the mood changes that can come with menopause make you crave comfort food to ease your anxiety or depression, changes your motivation to exercise. And it's a really busy time of life. A lot of times we're at the top of our careers. We have teenagers, we have parents that are feeling all the things, and we're in the middle trying to juggle everything. And we just don't have the time to take care of ourselves or be as active as we did in our earlier years. I'm not going to go into detail on this, but again, just another nerdy slide. As I am a physician and I like pictures, but this is the actual mechanism of what happens with the metabolic changes and what estrogen supports. Hormones for metabolic health. So I cannot technically tell you that hormone therapy can treat your diabetes. But we do have several studies showing there's a decreased incidence of diabetes ranging from 20 to 35%, depending on the study. Hormones do not necessarily help weight loss, but it can help with body composition. And hormones improve our sleep, and again, and our mood, and all the downstream effects of being more rested. Next, we talk about the brain. So there's thought to be, this is a little bit more of a gray area on the data, but there's a possible link of estrogen to our brain health. Again, estrogen, anti-inflammatory, the CEO of the hormone system, and especially the CEO of the brain. Our brain craves estrogen. It helps us have this anti-inflammatory effect in the brain. And one thought of a possible mechanism of dementia is neuroinflammation and potentially a decline in our estrogen contributing to that. And now we know that dementia is actually a change that starts in our brain years before our diagnosis, mainly from lifestyle factors and metabolic disease. So if you're 45 and male, your risk of dementia is 10%. If you're 45 and female, your risk of dementia is 20%. And it starts in your 40s. Doesn't start at 65 or 70 when diagnosis is made. So this picture, if you really want to geek out again on more information, Lisa Mosconi, she's a researcher who's actually doing research on hormones in the women's brain. Menopause Brain, great book, but she is doing the research. And this is a PET scan. This is showing the uptake of glucose in a premenopausal brain. All the red spots are where we take up glucose before our hormones start to change. In perimenopause, you see it starts to change here, early menopause and late menopause. Our brain actually changes the way we use glucose. And then this is her most recent study in 2024. This is actually, she designed a way to look at the estrogen receptors in our brain. This is before menopause. The little red dots are the estrogen receptors. Our brain craves estrogen so much, it upregulates estrogen receptors. Look at how much red is over here. This is post-menopause. It upregulates the number of receptors, so it's looking for any little bit of estradiol that's left. It really, really wants to have that hormone to help it function. So it's not just menopause that contributes to dementia risk. And I want to have this picture in your brain. So diabetes, smoking, excessive alcohol use, obesity, high blood pressure, traumatic brain injury, being physically inactive, depression, and high cholesterol are known to contribute to dementia later in life. So this is the time to start thinking about how can you improve on your care of yourself to decrease your risk if you want to protect your brain. So what we see, so estradiol, again, the CEO of the women's brain and the hormone system. It's neuroprotective, helps grow new brain cells, boosts the brain's ability to respond and adapt to all sorts of changes, helps balance serotonin, our mood hormone, protects the brain and heart from vascular damage, reduces production of beta amyloid, and prevents buildup of tau protein. So these are the key words. If you've ever heard any lecture about dementia, these are the proteins that build up in our brain, and also ensures glucose is used efficiently. Okay. So hormone therapy has been shown to benefit cognition in women who go through early menopause. So heaven forbid someone has gone through menopause early, either because of genetics, or there's some women, if they have a high risk gene, you've heard of BRCA genes. So women with a breast cancer risk gene called BRCA1 or 2 are advised to have their ovaries out before a certain age. And those women, if they don't go on hormone at that point, have a much higher risk of dementia. So we see their risk decrease if we put them on hormones when their ovaries are removed. And then we did see in the Women's Health Initiative, so remember that there was women that were early and we saw there was benefit in women who started hormones early. If women started hormones later, there was actually a subset in the Women's Health Initiative that if women started hormones and already had cognitive decline, so already had signs leading to dementia, they did not have any improvement, and there was potentially a risk with hormones. Again, this is a little bit more of a gray area in terms of our expertise and data on hormones in the brain, but there are people who are actually doing the research. Okay, last silent symptom, heart silent symptoms. So we already talked about the C word. Everybody's afraid of the C word. I want you to, another thing, other than vaginal estrogen saves lives. Heart disease kills women. Heart disease is the leading cause of death in women. It's not breast cancer. We're surviving breast cancer, even if we're diagnosed with it. Heart disease kills women. 1 in 5 women will die from heart disease. This is data from 2021. Couldn't find a cooler graphic, so I have old graphic, but new data on the right side of the screen. 1 in 5 women will die from heart disease. That's data from 2021. 47% of female deaths are from coronary artery disease.
What does CAD stand for?
Coronary artery disease. Yep. Heart health declines rapidly after menopause. So this is, see if I still have my, okay. So 20s to 30s, 40s to 60, our heart disease risk is less than men's. 10 years from menopause, our heart disease risk equals or increases more than men. They still have their hormones. Damn them. If men's testicles turned off, or excuse me. No, in reality, right? So if their testicles shut down, don't you think we would have figured this out by now? Like women's do? Oh yeah. So heart disease kills women. You need to be on top of your risk factors for coronary artery disease. So estrogen has a lot of effects on the heart that we don't think of. It's anti-inflammatory. It modulates the function of the lining of the arteries. We actually get an anti-inflammatory effect. It makes our ovaries a lot more fluid. And when we drop our estrogen, our arteries get stiffer. It releases nitric oxide, which opens up the arteries. It supports our natural pacemaker function. So that's where palpitations come from. I know I said not so silent or silent symptoms, but a lot of people don't know about that support. So estrogen actually supports our pacemaker, our natural pacemaker of our heart. Delays the formation of plaque, supports a healthy lipid profile, helps support mitochondria. So mitochondria are the energy makers in our cells. So it supports that in the heart and the rest of the body. Reduces the risk of the heart muscle thickening and protects the heart from high blood pressure and remodeling of the big valve or big chamber of the heart called the ventricle. So it prevents basically a buildup, which can lead to heart failure. Hormones for heart health. Women who start hormone therapy within 10 years of menopause are less likely to die from cardiovascular events and have a lower risk of heart attack. This is that data that actually came out from the Women's Health Initiative. And there are a lot of other studies that I don't have time. If we did one of these silent symptoms, we could go through every single data point out there, but we don't have time for that. So in 2020, the American Heart Association actually went through all the data, and they have this big paper. But basically the paper said, the transition of menopause is an independent risk factor for heart disease risk and mortality, independent of aging itself. They also stated that early initiation of hormones is associated with cardiovascular benefit. Did anybody hear about this? Exactly. So my cardiologist said, you should go on hormones as soon as you can. Okay. So I like to put this slide in because this is where most women in the menopause transition live, right? They're always juggling everything. They never take time for themselves. Well, what is menopause? It's the time to pause. Time to pause and focus on your own health. So this is knowing this data. Thank you for showing up. Tell your friends, read some of these books. and learn how to start taking care of yourself at this point. Menopause is going to happen. We're trying to do everything, but it's time to start taking care of the person in the middle. I don't have time to do all of the lifestyle interventions. That's a whole other talk, and we could do another one. But the main pillars of taking care of yourself would be avoiding toxins, quit smoking, stop drinking excessively or stop drinking altogether, make time for community and meaningful connections. There's a lot of data that supports the overall health of an individual, man or woman, with this particular pillar. Learn to manage your stress, prioritize sleep like it's your job. Exercise, and learn about how to take care of yourself with nutrition. It seems like there's this cliff that we hit in our with our perimenopausal transition. Our bodies just put up with our bad habits until they don't. We drop off this cliff, and I start to see this transition with my patients in their 40s. That's the first cliff. The next cliff is 10 years after menopause, another drop off in chronic disease risk and health. And then 70 is a magic cliff as well. That's where if you can make it to 70, great, but you better have really done your work, because 70 is another cliff where health just really starts to decline. Know your numbers, blood pressure, cholesterol levels, ask for a diabetes check, maintain a normal weight. Things that I know everybody poo-poos BMI, but get a body composition to bone densitometry, know your waist to hip ratio, check your bone density, get a CT calcium score, be up to date on your preventative screenings, pap smears, mammograms, colon cancer screenings. Again, I wanted to go through some of the benefits we talked about tonight of hormone therapy. So the only approved benefits that we see that I can say that these are approved indications for hormone therapy are hot flashes, night sweats, bone loss prevention, premature menopause, so if you go through menopause early, and then prevention and treatment of the genitourinary syndrome of menopause that we talked about. And then these are the benefits that benefit our silent symptoms: improving our sleep, especially in those with bothersome vasomotor symptoms. Hot flashes may decrease risk of cardiovascular disease. I cannot tell you it definitely does, but the evidence greatly informs me that I believe in it. I tell this to my patients: you have a decreased risk of cardiovascular disease if we go on hormone therapy. May slow down accumulation around your organs. That's what that means. May reduce your risk of type 2 diabetes and improve your glycemic control. Reduces fracture risk. Can improve your joint health and reduce your joint pain. May support healthy brain function. Improves genitourinary health. Improves quality of life. If you ever talk to someone who is before hormone and after hormone, their main statement, and what I'm looking for when I see a patient back in consultation, is, I feel like myself again. And reduces all-cause mortality, or reduces risk of death. So just leave you with this. So this book, if you haven't read this book, Kelly Casperson, she's a urologist and now hormone and sexual medicine expert. In her chapter that's Can Hormones Therapy Prevent Disease? If there was a medication, a supplement, a rectal suppository, anything that made men have a 30% decreased risk of death between the ages of 50 and 60, you think they'd be on it? Bleep yes. So I hope you've learned something about the silent symptoms of menopause or the health risks of menopause. Again, menopause is a natural process, not necessarily a disease process, but the natural processes that happen because of our decline in hormones can become disease. So please take that home, as well as what? Vaginal estrogen saves lives. Heart disease kills women. Questions?